Now let us discuss about the risk factors leading to retained placenta. Number one, what are the risk factors according to you all? So we'll divide this into three subheadings. There are risk factors related to poor uterine contractions which have led to uterine and atony. Which could be these risk factors which lead to poor uterine contraction? Number one, it could be high parity. Second, it could be prolonged use of oxytocin. It could be multi-fetal gestation as well, where there is uterine overdistension, wherever there is atonicity. Don't take it very lightly. There could be a uterine atonicity will not only cause atonic PPH, it can also cause retained placenta, which will further aggravate your PPH and morbidity of your patient. So prolonged use of oxytocin. Second category, epidural presentations, epidural analgesia, yes, they can also predispose to retain placenta, but it is not yet documented in any of the studies and it is not yet a documented risk factor. But you are right, it could possibly result in one of them. Risk factors related to, second is risk factors related to abnormal placentation. Which are, number one, history of uterine surgery. Suppose it's a primary patient, will you suspect a morbidly adherent placenta? Give me few examples where a primary patient or like without any previous cesarean section, patient develops morbidly adherent placenta. Give me two examples. History of prior uterine surgery. Second is IVF conceptions. Documented to have high probability of retained placenta and due to abnormal presentation. Myomectomy, previous check, curettage, absolutely correct. So here I would like to give you one example. We had one patient in Ames with us. She was a consultant of medicine at another Ames hospital. And she was referred to us with a history of preterm, which is like leaking since 18-19 weeks. She had a pre-viable preterm, but it was a precious pregnancy, and she was a primary patient. Her husband was also into a good, he was also like high profile. He was a faculty with us at Ames Delhi itself. Good profile patients, but because of her pre-viable preterm, we continued the pregnancy till 26 weeks. 26 weeks emergency CS was done. We could not salvage the baby. Although Ames NICU was considered as one of the best NICU of Asia, but the baby could not be salvaged because of extreme prematurity. We lost the baby. We could obviously help the patient. Question to you all, why we would have considered doing a cesarean at 26 weeks when we knew there is a doubtful prognosis of the baby? So I'll give you one hint. So patient prevention of intraventricular hemorrhage, yes, possibly. Actually, it was a maternal factor. She had a history of myomectomy during her MBBS days because of AUB, and there was a morbidly adherent placenta. She had focal accreta, primary patient with a history of myomectomy. Dr. Sarita has correctly mentioned myomectomy. Sometimes, patient might not remember, you might not remember. And this history, when she was back in the other Ames, this history was not elicited. She had low-lying placenta. She would leak with blood. It was always a blood-tinged leakage that we would observe on her pad. She was admitted in the labor room itself for almost a month. And we would often wonder, why is she having? Then a scan was done. Obviously, it was detected it's a low-lying placenta. And then there was a suspicion, clinical suspicion plus an ultrasound suspicion that the interface, the endometrial and the placental myometrial interface is very hazy. Suddenly, one day, I think when we were taking a vaginal swab for culture sensitivity, somebody just observed the scar on her abdomen. See, she, being not being a gynae, could not have given her entire history, right? It is your duty to take the entire history, and being a little high-profile patient, the VIP syndrome, you often tend to miss out on the basic history. You know, you are just doing the other things, you're doing all the advanced things and the hi-fi things, and you miss out on the history part. So when we were taking a vaginal swab sample, I just noticed there was a scar on the abdomen. I said, "What, ma'am? What surgery has been done?" She said, "I have a history of myomectomy." We immediately ordered an MRI for her. Obstetric MRI was ordered, and it turned out to be a focal accreta, and that was the reason she landed up into a preterm. So then 24 weeks, we could neither terminate the pregnancy on preterm basis. We knew she might need a hysterectomy even if we terminate this pre-viable preterm. The decision became so difficult after that. So we thought, let's continue the pregnancy. At least we can achieve fetal viability, and NICU being one of the best, we thought we could salvage the baby. Obviously, the outcomes were bad. So my impression to you all is, do not ignore your patient's history. Always examine. Local examination is visible. Inspection of the abdomen is so important. You might pick up scars. You might go into depth to discover patient's history. You might end up making better diagnosis for your patient and give better outcome to the patient. We had to put uterine artery balloons for her before we took her for cesarean and did the focal resection of the placenta from the acute scar. So next is other risk factors. If we go and check, other risk factors are, number one, dinner time already for all of us. So number one is preterm delivery. Second is congenital uterine anomalies. Third risk factor is prior history of retained placenta. So whenever a patient is undergoing normal labor, also do ask in your previous obstetric history, was there any peripartum event? Did you land up in PPH? Was there a manual separation of placenta? So all that has to be mentioned in detail when you are taking your obstetric history. And I hope you all are attending Dr. J.B. Sharma sir's mock exams, where Dr. Tejas is doing a great job by presenting such wonderful cases. I think as a resident, I would also never be able to present such wonderfully how Tejas presents. It's really commendable. So prior history of retained placenta is, these are the other, Dr. Tejas is giving context. No, Dr. Prathamesh, it's not like that. It's in a way, we make it so comprehensive so that you know the true art of history taking in exams. This is mock. It's not a complex, but it's a way to learn from your senior how well he presents, and you can do it better than him maybe someday. In your exam, you have to do better than him, okay?